everybody, welcome to Dr. Ghost YouTube channel. Prepping PG entrance one topic at a time. Please like, share and subscribe. Hope you enjoy.
Hello guys, today we'll talk about the topic of stroke. Okay, so what happens in stroke, how do we manage the stroke? So basically we know that there are two types of stroke. That is a hemorrhagic stroke where the blood vessels rupture, and an ischemic stroke where there is an occlusion of blood vessel. Okay, so we'll talk about how do we manage when a patient with stroke comes to our OPD. This is very important topic from exam point of view. It is repeatedly asked in NEET, PG and INI. Okay, so stroke, how do we means whenever a patient at emergency comes to us, how do we recognize that it's a stroke patient, or how do we suspect that this is a patient of stroke? We'll know that this is stroke by seeing the patient's symptoms, which can be remembered with the help of mnemonic face fast. Okay, where F stands for face means there will be something facial weakness like deviation of mouth, loss of the nasolabial folds, and there will be loss of creases. And A stands for arm. Arm means there will be arm weakness, like the patient will complain that he is unable to lift his arm or hold anything, right arm or left arm, whichever side stroke is there. Okay, depending on that. Now S stands for speech. Now the patient's speech will be slurred. We can ask the patient to. Now S stands in fast for speech. Okay, in speech means the patient will have slurred speech when you ask the patient to talk, or their family will give history that he's talking, or he or she is talking in a slurred way. Okay, and we also have to check that T stands for time. We have to check that since when these symptoms have started, that is facial weakness, arm weakness, slurred speech. So that time is very important in management of stroke. Time is tissue in these cases in a stroke patient. Okay, so this is how we can get to know that a patient which has come to ER can be suspected of stroke by the mnemonic fast. Okay, so whenever we suspect the patient to having stroke, the first thing in emergency we'll do is we'll order a NCCT head for the patient. What NCCT head does, like NCCT head cannot tell about ischemic stroke, okay, but it can definitely rule out hemorrhagic stroke. So what happens is the management of these two strokes is completely different. So we do NCCT head as soon as the suspected stroke patient comes to rule out hemorrhagic stroke, because ischemic stroke will not show much changes or will not show any change almost in the CT scan initially. Okay, so we'll do NCCT head to rule out the hemorrhagic stroke. Okay, so once we have ruled out that it's not a hemorrhagic stroke, we'll know that this is an acute ischemic stroke. Okay, so how will we will manage the ischemic stroke? Okay, so this is managed by the time criteria. Okay, if the symptoms, that is FAS, facial weakness, arm weakness, slurred speech, these symptoms have begin within the 4.5 hours, like the patient gives history that this person accompanying the patient gives history that these symptoms have started in less than 4.5 hours, then the patient will be eligible for IV TPA. Okay, IV TPA we have to give with the patient. If there are no other contraindications, we'll talk about contraindications of giving IV TPA in the next slide. Okay, so if the symptoms have started within 4.5 hours, the patient is eligible for receiving IV recombinant tissue plasminogen activator, that is thrombolytics. Okay, thrombolytics. But if the symptoms has started for more than 4.5 hours, so in these cases we have to get done the CT angiography of the patient first. Okay, so CTA means if the symptoms have started for more than 4.5 hours, we have to do CT angiography. We cannot give thrombolytics directly, because the risk of bleeding in thrombolytics after 4.5 hours is much more compared to the benefit we are receiving from giving the thrombolytics. Okay, we have to do CT angiography, and when we do CT angiography, we have to check for LVO. LVO means large vessel occlusion. Large vessels are like internal carotid artery, middle cerebral artery part 1, part 2, and basilar artery. These arteries are large vessel occlusion. We have to see that on CT angiography. So if the CT angiography is done, we have to see large vessel occlusion, and if the large vessel occlusion is present and the patient's symptoms have started in less than 6 hours, that is 4.5 to 6 hours, then we don't have to do anything else. We have to directly, after CT angiography, we have to directly go for mechanical thrombectomy. Okay, mechanical thrombectomy means we insert a catheter endovascular and break the clot. Okay, now if the symptoms have started in 6 to 24 hours, okay, like the symptoms started before 8 hours or before 10 hours, in these cases, after we do CT angiography, we see large vessel occlusion, we have to also do CT perfusion scan. Okay, we see a penumbra which can be salvaged around a dead tissue. If there is large vessel occlusion and there is a penumbra, that is the patient is eligible for getting a mechanical thrombectomy, that there will be a large vessel occlusion present and there will also be a penumbra, then patient should again undergo mechanical thrombectomy. Okay, this is how basically a stroke patient is managed. Okay, if a suspected acute stroke patient comes, what we have to do first is we have to get an NCCT for all the suspected stroke patients. So, and now if the one set is less than 6 hours, okay, then NCCT head shows no hemorrhage. Okay, no hemorrhage. Now if the patient is eligible for TPA, that is tissue plasminogen activator, eligible means the patient symptoms have started in less than 4.5 hours. Also other indications are, I have written it in the lower box, that there will be the symptoms have started in less than 4.5 hours and the CT scan shows no hemorrhage, then only we can give. I have told you already that this management is for ischemic stroke and not the hemorrhagic stroke. And one more important point is there should be no edema of more than one third in the MCA territory. Okay, the edema can be present, but it should be less than one third of the MCA territory, and the age of the patient should be more than 18 years. Also, if the patient's BP is consistently more than 185 by 110 despite the treatment, like we can give nifedipine, labetalol. If despite the treatment the patient's BP is more than 185 by 110, we cannot give the thrombolysis. Okay, also if the patient has any bleeding diastasis, that is bleeding disorders, of if there is a recent head injury or there is a recent myocardial infarctions, you can go through this slide. Okay, if the patient is now, if there are no contraindications and the time has been less than 4.5 hours and the patient has no edema of more than one third in the MCA territory, then the patient is IV tissue plasminogen activator eligible. If he is eligible, yes, then we have to give IV TPA. Now, if he is not eligible, that is the time has been crossed, then we have to perform CT angiography. I already told you in the previous slide. If he is not eligible, then we have to perform CT angiography and look for any large vessel occlusion. Large vessel occlusions are ICA, which will be internal carotid artery, M1, M2 part of middle cerebral artery or basilar artery. Okay, if there is large occlusion present, we have to go for thrombectomy, that is MT, mechanical thrombectomy. Okay, if large vessel occlusion is not present, then we have to go for inpatient management. Okay, now if the one set is between 6 hours to 24 hours, okay, then I told you if the one set is between 6 hours to 24 hours, and we will obviously do NCCT to rule out hemorrhage. Along with that, we will do CT angiography and CT perfusion. CT angiography will show large vessel occlusion and CT perfusion will show the salvageable penumbra. If these things are present and he is eligible, then we will go for thrombectomy again. Okay, and if not, then inpatient management. Okay, so now I have written down the things for you and made it simpler here. Okay, so talking about stroke protocol, whenever we have a patient with suspected stroke, I told you how we do with suspect stroke with the help of mnemonic fast, that there will be facial weakness, arm weakness, slurred speech, and we have to look at the time, that is one set is before 6 hours, before 4.5 hours, or between 4.5 to 6 hours, or between 6 to 24 hours. Okay, now once we suspect that this is a patient of stroke in emergency, what I told you that we have to get the NCCT head of all the patient. So why do we need NCCT head? First thing is to rule out hemorrhagic stroke. I told you the management of hemorrhagic stroke is completely different from ischemic stroke. Now once we have ruled out hemorrhagic stroke, we have to also rule out one more thing, that the MCA territory edema is not more than one third. I told you that the indication for receiving our TPA, recombinant TPA, was that the MCA territory edema should be less than one third. Okay, otherwise there is high risk of bleeding on receiving the thrombolysis. So on NCCT head we have to rule out two things. First is hemorrhagic stroke and second is MCA territory edema more than one third. Okay, when these things are ruled out, also we have to get a blood glucose done. Okay, blood glucose done because if the blood glucose level is less than 60 milligram per dl, or the blood glucose level is very low, it can mimic a stroke. Okay, so we should get blood glucose level done in the ER. Okay, now once these are done and the hemorrhagic stroke has been ruled out, low blood glucose has been ruled out, and MCA territory edema more than one third has been ruled out, and if there are no contraindication I mentioned in the previous slide, then, and also the BP should be less than 185 by 110 mmHg after giving BP lowering agents, and one shot should be less than 4.5 hours. If these criteria are met, okay, then the patient is eligible for receiving RTPA. Okay, that is recombinant TPA or thrombolytic. Earlier LT place was preferred, but in the recent books the 1080 place is preferred these days. So I have mentioned both, but earlier LT place was preferred, but recently the books have started mentioning 1080 place also. Okay, on giving recombinant TPA or thrombolytic, there is 6% risk of bleeding also. Okay, once we have given the recombinant TPA, okay, once we have given the recombinant TPA, it's not like we can send the patient home or that's it, enough. We have to get done the patient's CT angiography. Here also we have to get done patient's angiography even if the patient's symptoms once set were less than 4.5 hours. Then we have to give thrombolytic, and after that we have to get done the patient's CT angiography and look for any large vessel occlusions. What are large vessels? I told you that is internal carotid artery, middle cerebral artery, part 1, part 2, and basilar artery. If the large vessel occlusion is present, again we have to go for mechanical thrombectomy of the patient. Okay, so it's not like that if we give a thrombolytic we don't have to do CT angiography. CT angiography will be done, but after giving a recombinant TP or thrombolytic. Okay, this is how we manage a patient. Now since we have talked about what to do when the symptoms onset was less than 4.5 hours, now we'll talk about what if the patient's symptoms has been for 4.5 hours to 6 hours. Okay, so anyways, even if the patient comes after 4.5 to 6 hours, what we have to do is we have to get the NCCT of the patient to rule out a hemorrhagic stroke and the hemorrhagic stroke. Okay, to rule out hemorrhagic stroke we have to always do NCCT scan. Okay, now once NCCT is done, in cases of more than 4.5 hours we cannot give thrombolytic to the patient because the risk of bleeding increases many folds after 4.5 hours. So what we have to do is we have to get the CT angiography of the patient. CTA stands for CT angiography, and if the CT angiography shows LVO means large vessel occlusion, then we have to go for mechanical thrombectomy. Okay, this is how we proceed. There is no rule of thrombolytic after 4.5 hours. Now if the one set is between 4.5 cut here. Now if the one set is of the symptoms was more than 6 hours up to 24 hours, then also we have to get an NCCT of scan of the patient, because to rule out hemorrhagic stroke. Now once we have ruled out hemorrhagic stroke, what we have to do is we have to get done a CT angiography as well as CT perfusion. Okay, the role of CT perfusion comes only after 6 hours of symptoms. After we do CT angiography and CT perfusion, like here also there will be no role of thrombolytic. I told you after 4.5 hours we have no role of we have no role of thrombolytic. So after NCCT we have to do both CT angiography and CT perfusion. CTP stands for CT perfusion. In CT angiography we look for large vessel occlusion, and in CT perfusion we look for mismatch score, which has to be less than 6. What is mismatch score? That is, there is a presence of salvageable penumbra around a dead tissue, okay, which can be salvaged by mechanical thrombectomy. If any of these two is present in CT angiography or CT perfusion, the patient has to undergo mechanical thrombectomy. Okay, this is how we manage a patient with stroke. I have taught you the patient of suspected stroke comes within 4.5 hours, after 4.5 hours till 6 hours, or after 6 hours to 24 hours. This is how we have to manage the patient, and this is a very important slide repeatedly asked in exams. Okay, thank you. Keep studying.